Most people do not know what to do when they see someone laying on the floor, shaking violently and uncontrollably. In many instances, they might assume that the person is possessed by some sort of spirit or that witchcraft is involved. This is one of many dangerous and deceptive misconceptions about seizures and epilepsy that discourages people from talking about it and deters them from seeking treatment. Yet, epilepsy is one of the most common neurological disorders, with the World Health Organization saying that some 50 million people around the world suffer from it. Why then is there so much stigma around epilepsy? Today, we're going to talk to some Namibians to find out what they know about epilepsy and debunk some of the myths around the disorder. So, Robin, can you please tell me what you know about epilepsy?
Epileptic is, I think, it's a condition. It's like mainly in your brain or something that it just walked by. Like I know a guy. He walked next to me and suddenly he just fell down. It's like and he started vomiting and so on. That's all I know really more about epilepsy.
In terms of misconceptions, and ideas that people have about epilepsy, what have you heard?
Well, not really much about what people say about epilepsy. It's just that it's an occurrence that probably in the genes of some person. Or
There was this thing people used to say that once they get that seizure attack, that's what I call it, the attack, apparently they produce some type of scent. If you smell it, you also attract it. But during the years when I grew up, I learned that was just a myth. Yeah.
Calvin, what do you know about epilepsy?
Epilepsy is, from what I know, a layman's point of view or an idea of it, is a disease that causes seizures or witchcraft, one of the two. Yeah. But yeah, that's how I understand it. You find that it affects a lot of people those who have epilepsy, they find that they've got seizures suddenly. I don't know the scientific explanation about it, but I've seen it before and I know about it, yes. In the village, we all know that when a person has a seizure or something, then it has to do with who has done what to who and so forth. So I don't know exactly the scientific explanation about it, but all I know is it creates seizures in persons with epilepsy. Yeah.
All I know about epilepsy is a disease that causes seizures that happen randomly. I don't know what actually causes it, but yeah, that's what I know. Like foam comes out of your mouth. A public perception for epilepsy, from what I've seen around people, is usually it's witchcraft. It's usually someone in your family line has done something to you. So that's what Namibians or Africans think about what epilepsy is. I'm sure it's deeper than that. I'm sure it's more scientifically. It's a disease at the end of the day. So yeah, that's what I know about epilepsy.
Good afternoon and welcome to Heartbeats. I'm your host, Arlana Shikongo. As we've just heard from some everyday Namibians, there is still some uncertainty and superstition shrouding epilepsy. So tonight, we're joined by specialist neurologist Dr. Vaya Vashirua, as well as the chairperson of the Epilepsy Namibia organization, Harmina Riphagen, to discuss this neurological disorder that is said to affect some 50 million people globally. We will also be joined by Pelagia Benjamin, a woman who has been living with the disorder for some years, and she will share her experience with us. Thank you for joining us on Heartbeat. To my guests, we're very happy to have you in studio. And to Pelagia, thank you so much for making the time to join us tonight via Zoom. So to get us started, I'm going to start with Dr. Vashirua. Let's just have a discussion on what epilepsy is, because as we saw from the public, there is still a lot of misunderstanding and lack of knowledge about epilepsy.
Right. Alana, thanks very much for having me here. It's always a pleasure to be able to participate in this type of discussions. Simply put, epilepsy can probably be understood as a disease of the central nervous system of the brain that is characterized by the occurrence of what we call epileptic seizures. And essentially, simply put, it's an episode where you have severely abnormal electrical activity within the brain. And that then causes the symptoms of epilepsy, which we describe as the seizures. So epilepsy is actually just a description of a disease that is characterized by having recurrent epileptic seizures. And hence we talk about epilepsy. Now, there are many different types of epilepsy, or at least epilepsy syndromes, and the body of knowledge has grown remarkably over the last 50 years or so, and especially also with the advent of special imaging techniques like CT scans and MRI, and also the invention of the electroencephalogram, which is a useful tool for identifying sort of epileptic dysfunction in the laboratory in patients. We have really identified a whole host of various epilepsy syndromes. And when it comes to the types of causes that we talk about with epilepsy, we try and classify epileptic syndromes as being either primary, as in the epilepsy is the problem, the primary problem in the brain, and there's not a secondary cause, or at least not one that we can readily identify. And we talk about secondary epilepsy, where something happens to the brain, be it trauma or an infection or stroke, etc., that then affects the way the brain functions and then leads to epileptic seizures. It's always important to remember that a single seizure does not define epilepsy, and a single seizure invariably is probably a symptom of something that has happened to the brain. And this, again, the something is a whole host and wide variety of things that can happen to the brain, ranging from metabolic problems like too high a level of glucose or too low a level of sugar in your bloodstream, to trauma, to infections, to inflammatory conditions in the brain. A whole host of things can cause epileptic seizures. And I think it's very important before you make a diagnosis of epilepsy in a patient that you want to identify treatable, reversible causes for the epileptic seizure itself. Try and define that, okay, the patient is having seizures. And if they are recurrent, then you say, okay, fine, I'm dealing with a patient with epilepsy. And then just in terms of a bit of nomenclature, we do not really like the use of the word epileptic. Rather, we describe patients with epilepsy or patients who have epilepsy. Just in terms of the wording that we use, I think is probably more appropriate. So in a nutshell, that's the understanding of epilepsy. Obviously, it's we're trying to simplify a vast body of knowledge, and I think it's important for the public to realize this. And I think later on in our discussion, we'll talk about the different types of seizures, different types of epilepsies, just in terms of trying to address some of the how they present clinically as well, and also try to debunk a couple of myths in terms of how patients with epilepsy present both in the home and at the workplace, etc., etc. But we can expand on that a bit later.
Absolutely. Thank you so much for that, Dr. Vaya. And just talking about the misconceptions and the stigma that surrounds epilepsy, Harmina, I know that with epilepsy in Namibia, a lot of the work is awareness, bringing knowledge and understanding to the community so that people have an understanding of what the disease is. So what would you say are some of the biggest myths or misconceptions that you find in the community setting when it comes to epilepsy?
I think to link with Dr. Vaya, the biggest one is the witchcraft. As he explained, I mean, it's a function and a dysfunction in the body. So there's nothing other attached to a person having a seizure. What we do understand is that a seizure is a dramatic occurrence. I mean, it's unnatural for people to fall to the floor. That's not the only seizures they are, but that is the one that normally gets them the worst name, which gets the bad rap.
Yes.
Is the witchcraft or that you've been hexed by something or that you are possessed. Also that people with epilepsy are crazy or that it is a mad person's action. That is about the worst ones we get.
Absolutely.
There are other ones that I say they have snakes in their stomach. We've heard that. We've also heard stuff like when people get too close to fire or are burned by fire, that the epilepsy will never go away or that they won't be controlled again. Unfortunately, all these things are just a lack of knowledge about how the disease works, what happens, and what kind of effect it has on a person's life. There's no way that you can say that a person with epilepsy is crazy. There's no mental health problem with epilepsy alone. There's also they're not sick like we understand sick people not being able to perform. When they don't have a seizure, they can perform normally. The only sign of epilepsy is actually the seizure.
Okay.
So there's nothing else. But I'm saying this again, epilepsy on its own, it's often connected to other conditions.
Okay.
So that we have to always be careful of, to explain epilepsy as not being an illness on its own.
Okay.
All right. The stigmas we have is that people with epilepsy need to be isolated. That really doesn't have to happen. It's not contagious. Not hereditary. You can't get it from somebody. Nothing will happen to you, unlike COVID, when you touch a person with epilepsy or help with a seizure or are close to them. There's no contagion thing. So it is really not a problem to live with a person with epilepsy or to go out with them or to have fun with them. There's nothing wrong. You can't get epilepsy from somebody else.
Absolutely. And that's important to note, because I think with that stigma, or rather the misconception of witchcraft or possession or anything like that, there tends to be this fear of being close to somebody because people assume that in some capacity it will be passed on to them. And that is a misconception in its entirety that completely needs to be dispelled.
The other side of the stigmas is that people with epilepsy are discriminated against, as if they have lesser capacity, lesser brain power, lesser intelligence. That is absolutely not true.
Yeah.
Same intelligence and more and better and less like normal population. The same kind of ability to learn or not to learn, or to work or not to work.
Absolutely. That makes me come to this idea, or rather questions that people had about the capability of somebody that's living with epilepsy. There are a lot of questions on, is it safe for someone with epilepsy to drive? Is it safe for someone with epilepsy to go for a swim or to travel, to be in an airplane? There's a lot of not understanding around that because the seizures can happen so randomly and so sporadically. So in terms of, the safety or what people with epilepsy are able to do, is it safe for them to conduct such activities? I'll start with you, Anna. Yeah.
You have to split it up. People with seizures may not drive.
Okay.
If you check with NATIS as well, if you apply for a license, it asks if you have epilepsy. If you're declared free of seizures for a certain period, it is different in different countries. And medically declared that you don't have seizures, you may drive again.
Okay.
But you have to prove that you may. For the sport and the swimming, in Namibia, I'm a bit scared to say yes, they can swim, because so few people can swim.
Okay.
It's not really about the epilepsies, but that they are not able to swim.
Okay.
So that bothers me more. They can swim with the right equipment, flotation jackets and with somebody. All sport we don't recommend it, but if you are a very good swimmer, there shouldn't be a problem if you have somebody with you who can help you if you have a seizure in the water.
Okay.
It is a bit of a delicate side, but it can be done.
Yeah.
Other sports are fine. We don't really recommend contact sports. Also not really for the person with epilepsy, but also for the injury.
Okay, yeah.
That is not, but as long as they are well trained, well equipped, fit enough, and with somebody who can play the sport, then by all means they can do it.
Absolutely. And then I guess that would also, as you said, depend on the treatment or how long it's been between a seizure or something like that. So in terms of thinking of that element of safety, Doctor, can you tell us, if, say, for example, if somebody is on a treatment plan, can they travel? Are they allowed to be in airplanes,
Sure.
things like that?
Well, whenever I encounter patients with epilepsy, which obviously I see quite a lot of, this is one of the very common questions that are asked in terms of what am I allowed to do, what am I not allowed to do. Okay, obviously I think one should always bear in mind that the problem with epileptic seizures is twofold. One is the unpredictable nature of when they occur, and I think in terms of disability for most patients, in terms of the impact on their lives, that that aspect of unpredictability is probably the most disabling part of epilepsy, of living with epilepsy. You can just imagine if you had a predictable schedule of when you're having your seizures, it's a simple matter of lying down on a bed, having your seizure, and life carries on. But unfortunately, it doesn't work that way.
Yeah.
And so when we're giving advice in terms of activities and potentially hazardous activities or behaviors, one has to keep this in mind that it's unpredictable. And the second thing is obviously during that time that you're having the seizure, you lose awareness typically of what's happening around you, and then you lose the ability to control your own body and act with sort of a direct intent during that time.
Yeah.
And that's where the risk comes in, essentially. And so when it comes to driving, just to echo, sure, patients are advised not to drive. Okay, and the risks are, and the reason for this are twofold. One, injury to the self, and obviously, probably more importantly, injury to other road users.
Yeah.
In terms of controlling a fast-moving 3 tons of steel is probably not a good idea. Having a seizure at that. So, but there are guidelines in terms of when it is safe to resume driving. As was mentioned, different countries have different laws and different sort of jurisdictions will have different guidelines. Okay, and also depending on the last time that you had a seizure and whether you're on treatment, whether you're not on treatment, and also depending on the type of driving you do, whether you do civilian driving or whether you're a taxi driver or like a professional driver, or whether you operate sort of heavy goods vehicles. Obviously, patients with epilepsy are not allowed to fly for obvious reasons. I think that doesn't require any expansion.
As a pilot.
As a pilot, obviously, yes. Right. But apart from those limitations, and again, when it comes to the swimming and participation in sports, again, I always encourage patients to try and live as normal life as possible. Okay? But the caveat is always, if you are going to swim, be sure that you alert people with you that you have epilepsy. Number 2, make sure that you never swim alone. And again, it's about the unpredictable nature of seizures and the risk. Okay, one cannot eliminate risk completely in one's life. We all know this. However, I always think of the nightmare situation of having a swim, doing a couple of laps, all by yourself, having a seizure. I mean, that's as dark as it gets, I would imagine. All right. In terms of risk of drowning, so it's always useful to have somebody with you that you have alerted. Listen, I have epilepsy. Please keep an eye on me, but I'd like to swim as well. All right. Short of those 2 limitations, I always advise patients, live your life as normal as possible, short of those, right? In terms of traveling, flying in an airplane, you're free to do whatever you want to do.
Okay.
All right. Take your medication and just watch out for particularly hazardous activities where you're alone and unsupervised.
Absolutely.
And of course, please don't drive if your doctor tells you not to.
Absolutely. And of course, aside from activities, there are probably certain things that someone with epilepsy should avoid. If it's, it's a chemical dysfunction that's happening in the brain, that means, for example, substances would affect your brain and your body.
Right.
So I'm guessing alcohol is probably one of those things that someone with epilepsy is asked to avoid. If we can expand on that, and maybe other things that they're asked to avoid.
Sure. Again, yes, I think the the hard and ready answer when it comes to that type of question, and in terms of toxins, for example, is yes, please avoid all toxins if you can, right? Avoid alcohol as much as you can, because obviously, especially when the alcohol is, let's call it, leaving your system, or at least the levels of alcohol are dropping, particularly you're at increased risk of having seizures during that period, which is oftentimes why we see patients with epilepsy who went on a binge will have an epileptic seizure, not when they're drunk, but when they are hungover the next day. So please try and avoid that. Obviously, one wants to avoid all stimulants as much as you can. And what we're talking about here, things like nicotine, caffeine, etc. All right. There are certain drugs, obviously, that are widely used that will increase your risk of having epileptic seizures. And so if you are known with epilepsy, it's important to highlight this to your healthcare practitioner whenever you have any encounter, in terms of making them aware that, listen, I do have epilepsy. Please do not give me medication that may increase my risk of having another seizure.
Okay.
Right? So yeah, and yeah, I think it's just sort of in terms of toxins and things to avoid. That is one aspect.
Okay.
The other thing that we do know really does increase your risk of seizures is sleep deprivation, for some other reason. And I think, and especially when it comes to young people, and we all know about the behavior of young people, we were all the young ones. It's important to highlight that sleep deprivation, especially in young patients with epilepsy, inevitably will increase your risk of having epileptic seizures. All right. And this obviously speaks to the management of epilepsy, because it's a chronic disease. Again, it's very important to highlight this, that your treatment is not short. You're not going to get rid of it within a month if you've been diagnosed with it. It's an illness that will that you will have to deal with for a number of years.
Yeah.
Okay, and so you'll have to adjust the way you live your life and your lifestyle a little bit to accommodate that reality.
Absolutely.
All right. Okay, and yeah, so these are the triggers, or at least the aspect or the factors that increase your risk of seizures that I've just mentioned. And I think these are the things that one just has to keep in mind when you are planning your life in terms of what you want to do for yourself.
Absolutely.
Right.
I'm curious, what happens in the brain when someone is sleep deprived that makes them more at risk of having a seizure? Is there research on it? What happens?
There is a body of knowledge on it, of course, as you can imagine.
Yeah.
Unfortunately, and this is said with respect, it would be difficult to summarize 10 years of knowledge in 5 minutes. It just won't happen, unfortunately. But we do know that it's got something to do with the activation that occurs during sleep. For example, we know that the sleep state itself of the brain actually does also increase the risk of seizures. So most seizures actually occur in sleep rather than when patients are awake.
Okay.
And I think this whole misconception that sleep is a passive process of the brain, probably as a sideline, needs to be debunked. It's actually a very active brain process. Okay, you actively sleep.
Okay.
And so the thinking is that the sleep state increases your risk of seizures, and if you don't get adequate sleep again, you get certain waveforms and certain discharges within the brain caused by the deprived brain that then increase your risk of having seizures.
Okay.
Right.
And then, go ahead, Harina.
Sorry, on the sleep, we normally explain to normal people is that when you don't sleep enough, you feel not good.
Yeah.
It's actually true for your brain as well.
Okay.
So if you don't sleep enough, your brain doesn't feel good.
Okay.
That's the simple
That's
one
the
we
simple
use.
version of it. Okay. No, that makes a lot of sense, because I think, like you said, we don't really think about the brain in the same way that we think about the body, because we don't actively see the brain and what's happening to it. So there's a lot of disregard for what's happening in the brain. But absolutely, sleep deprivation will harm anybody's brain and will be a problem for anybody. I completely understand that. So then I just want to move over a little bit into getting an understanding of the different kinds of seizures. I'm sure that with your awareness, you talk people through this probably a lot, Armina. So please tell us a little bit about the different type of seizures that someone can experience.
We normally talk about the 3 different kinds of seizures in 3 categories, where we have the full seizure. Dr. Vaya will put the big names on. We say the full seizure, where people fall to the floor, shake. The foam is not as often as you think.
Okay.
And are unconscious. So that's the complete big seizure, the one most people see. The other one is where part of the brain is in the seizure.
Okay.
So people might be conscious and they might walk around or talk or wonder, or they often pluck their clothing,
Okay.
or they do things repetitively, but and sometimes halfway conscious.
Okay.
They know what's going on, but they're not registering what's going on.
Okay.
And then you have what's called an absent seizure, where it's very short, and it's often in young children, just that moment where they don't know what's going on. But
Okay.
they stay conscious, but it's very quick.
Okay. All right.
So these are the three simple ways to recognize the three big groups of seizures.
Okay. Doctor, is there anything that you want to add on to those descriptions of the seizures?
Yes, no, again, we need to obviously simplify a very complex body of knowledge here.
Yeah.
But I think, simply put, I have to sort of echo that. So probably the best way, and I think this relates to identifying when patients are having seizures or when somebody's having a seizure, is again, the way I teach the undergraduates about epileptic seizures is that you're looking at an episode or time where a patient has abnormal behavior.
Okay.
Okay, that is transient, that is for short-lived, for a couple of minutes, for whatever cause. Okay, and then once you've identified that this individual has episodes of abnormal or distinct episodes of abnormal behavior that is weird, for whatever the cause, then you have a suspicion. Okay, maybe I'm dealing with an epilepsy syndrome here. And then we talk a little bit about how the seizures occur. So some patients will fall and shake to the ground and have what we call a generalized tonic-clonic seizures. Please forget the fancy words. These are not important. Okay? And that's your typical epileptic syndrome where people shake violently and sometimes lose control of their bladder and sometimes will bite their tongue in the mouth, maybe have foam coming out of the mouth, etc. These are violent seizures, easy to recognize, and the vast majority, and because it's so easy to recognize, the vast majority of lay people are familiar with that type of seizure.
Yeah.
Right? There are, however, a whole host of other seizures where patients may, for example, typically have what we call an arrest of behavior. And this is the so-called absent seizures that we call, where the person is fine and suddenly they stop doing what they're doing and they carry on doing what they were doing. Okay? And during that brief time, which can be variable in terms of the duration, the patient has had a seizure.
Okay.
And then you get other seizures where you have what we call complex partial seizures. That's an old term that we used to use.
Okay.
Where you have a seizure, the patient is awake but not alert, or they have lose awareness. So the thing that differentiates a lot of these epilepsy syndrome is, does the patient lose awareness of what's happening around them or not?
Okay.
And I think the way the epileptic seizure comes, and this is obviously the forte of your healthcare practitioner, and I think if you have a suspicion, please go to your healthcare practitioner and have yourself checked out. It all depends which part of the brain is being affected. So sometimes, depending on if it's in the visual center of the brain, people see colors. Or sometimes if it's in the auditory center of the brain, they hear a typical song, etc. Or maybe have odd smells that occur before that, depending on which part of the brain the seizure is originating from.
Okay.
Right? And then depending on whether the seizure activity spreads to involve the whole brain, patients then lose awareness or not. Okay. And as I said, the fancy words are not that important. And I think what's really important is recognizing that this individual is having episodes of abnormal behavior, which is never normal, and there are distinct episodes and they're short-lived, perhaps what we're dealing with are epileptic seizures.
Okay.
And that's when you engage with the healthcare providers to obviously confirm your clinical suspicion and then plan treatment, etc.
Okay. Is that then to say, does it progress the type of seizure that a person might have? Yeah, go ahead.
Okay, so yes, so typically, well, and there are very different types of seizures, as was mentioned. So, but the most common occurring type of seizure is the seizure that starts in one part of the brain. Okay, and most patients, or quite a number of patients, will report to you that I get a feeling before the seizure happens that something is going to happen. Right, and in fact, that feeling, it's called an aura, is actually a small seizure that has started somewhere in the brain, okay? And that sensation that you're feeling is because there's a seizure happening somewhere in the brain. And then, if you're lucky, it stays local to one part of the brain and doesn't spread. If you're unlucky, which unfortunately happens with the majority of patients who have focal onset seizures, is that then the epileptic activity then spreads to affect the brain. And if it then reaches the deeper structures of the brain and then sort of spreads and affects the whole brain simultaneously, then you lose consciousness.
Okay.
Right? And you fall down and you shake, etc.
Okay.
Right.
And then in an instance where, someone is having a seizure, a noticeable seizure, let's say they fall and they're convulsing, what is the best thing for somebody to do, Harmina, in that circumstance? Because I know that a lot of people are fearful of, if I touch the person, what will happen? Or there's usually thought about, are they going to swallow their tongue and that kind of thing? So what should somebody do when they're seeing that happen?
Our normal advice is as little as possible.
Okay.
We say you time the seizure any way you can, whether you count, sing a song, say a verse or whatever, so that you can recall the time, because knowing how long a seizure is very important. Normally around about a minute. It feels much longer, but not. Protect the head any way you can. You can put your foot under, you can put a scarf under and swing it a little bit up so it doesn't bump. Just avoid the injury. But please not to touch, restrain, put anything in the mouth, nothing of that sort. You can wait for the seizure to stop.
Okay.
This story of swallowing your tongue, you can't.
Okay.
It's not possible. You can try, but it's nicely attached.
Okay.
You can't. What you hear is the spasm of the body and the oxygen. So that's not the tongue. They do bite their tongues, but please keep your fingers out of the mouth. It is a dangerous area. They will bite your finger off sometimes.
Okay.
They can get hurt on the teeth and on the jaws. So that is painful. And also restriction of the body is painful.
Yeah.
So don't do it unless there's danger.
Yeah.
Then you can either move the stuff away or something. But that is for the big seizure. And then you turn to the recovery position so that the airway, once the seizure stops, can be clear. And please stay with the person until they recognize what has happened.
Okay.
So that they can either wait it out, call somebody, or so. There's no need for immediate medical action unless the seizures are long and don't stop. We talk about 3, 4, 5 minutes,
Okay.
not stopping. If it comes and goes, you have another kind of almost emergency.
Okay.
And for any blood.
Okay.
If there's injury, then you call. For the other seizures where people wander, talk, do strange things, you can just guide them if they walk away from danger. That's all. Then normally it's easier when you guide them from the back on the hips, so there's no disturbance in their pace.
Okay.
And see that they don't walk in front of cars or fall over stones or stairs or something like that.
Okay. And
Just keep safe.
Harmina, you mentioned the recovery position. Can you elaborate on what that is? What is the recovery position?
It's normally on the left-hand side,
Okay.
where you stretch one arm out and the head to the side and one leg up,
Okay.
so that all the airways are clean and the people can start breathing again.
Okay. All right. Thank you for that explanation. And then...
I need to add.
Oh, go ahead,
just in terms of what to do, and I fully have to echo everything Amina has mentioned, but it's vitally important that you time the seizure. If you can get a watch, most people have a cell phone, time it. And the reason why it's important to time it is because should the seizure last longer than 5 minutes, that is a dire medical emergency. Okay? It's a condition we call status epilepticus, and that patient needs to get taken to hospital as a matter of urgency, because status epilepticus is a very, very bad thing and is a severe medical emergency. So please do not watch a patient having seizure for 5-10 minutes and not take them to hospital, which is why it's important to time it. And the reason why we encourage people to time the seizure is because if your loved one is having an epileptic seizure, time tends to dilate and your whole perception of how long things take is completely flustered. So time the seizure, if it lasts longer than 5 minutes, as quickly as possible, get that patient to hospital.
Absolutely.
Right. And obviously, if the patient has recurrent seizures and does not wake up in between, again, that is a dire situation, the patient needs to go to hospital as soon as possible.
Okay. And then, doctor, especially with those extended type of seizures, what's happening to the brain in that moment? Is there oxygen getting to the brain? What's happening there?
So bad things are happening in the brain at that time. So firstly, because you're having this abnormal discharge, almost like an electrical storm, let's call it, in the brain, the amount of oxygen and glucose or sugar that your brain uses at that time spikes and goes all the way up, number one. Right? And unfortunately, also the epileptic seizures itself causes the release of many what we call neurotransmitters, chemicals within the brain that further damage the brain or harm the nerve cells by the mere fact that you have this abnormal electrical storm and all these chemicals are being secreted within the brain. And you have increased use of oxygen in blood, plus all these sort of toxic chemicals being secreted by the brain itself, right? And that is a soup of absolute disaster happening in the brain, which is why we encourage patients, if it's lasting longer than 5 minutes, that's an emergency. Take them to hospital, please.
Okay. And then in terms of the long-term effects, because I can imagine if, say, for example, somebody's not on treatment and this is something that happens continually, what are the long-term lasting effects that person might experience?
Right. Yeah. So back in the 1800s, there was a phrase that came of like seizures beget seizures. So what that basically means is that look, the individual epileptic seizure is probably not a harmful phenomenon if it's short, less than a minute, as was mentioned, which is the vast majority of epileptic seizures, thankfully. But we do know that when patients have recurrent uncontrolled seizures persistently again and again, we do find a state where the seizures actually, number one, become worse and epileptic syndrome becomes worse as a result of these uncontrolled seizures, number one. And number two, unfortunately, injury to the nerve cells then starts occurring. And then we start talking about epileptic encephalopathy, I forget the fancy words, essentially injury to the brain secondary to recurrent uncontrolled seizures. Right? And that is unavoidable, which is why we insist or we encourage patients that if you do have seizures, please present. And do not watch patients having recurrent episodes without attending to your healthcare provider. And if need be, seek additional expert help if the patient is not having adequate control with one drug or two drugs. We'll talk a little bit about that just now as well.
Okay.
Right.
I think I'm just seeing some comments here that I think I want us to just quickly address while we try to get Pelagia back on screen to talk to us. But we have Emmy Junior Amunyela asking, how can parents or teachers differentiate child absent seizures from mere blurring? Also, is this an indication of possible epilepsy? I'll repeat that again, and I think, Doctor, you can help us with this one. How can parents or teachers differentiate child absent seizures from mere blurring? Also, is this an indication of possible epilepsy?
Right. I think the very first thing, as we try and answer that question, it's important to realize that the human brain was never designed to lose consciousness. Okay? You're not supposed to ever lose awareness. And so if you do lose awareness or lose consciousness, something is happening to your body, right? And you need to really find out what is the matter. So it's not a small thing, and it's not a matter to rubbish when somebody loses awareness. And I think to try and answer the question, so what happens with absent seizures is patients typically have what I call arrest of behavior, which means they're busy doing something and they stop doing whatever they do for a short while. They do nothing and they carry on. If it's very short, it can be missed, definitely. However, also what we do find with kids with absent seizures is that oftentimes they're associated issues. They have behavioral difficulties sometimes, and particularly school performance may go down. And that's a very early warning sign in terms of teachers to look out for. When you have a child who's been generally well, who suddenly has dropping their school performance for unexplained reasons, and maybe a little bit more inattentive in class, maybe a little bit more naughty, so to say, in class. These are all early warning signs that perhaps there's something really severely wrong happening in the brain. And that's with school performance. In very severe cases, obviously, you may have developmental slowing, where kids are not meeting their milestones appropriately. And again, you need to watch out for these things and present as soon as possible, because it's never normal for someone to to lose consciousness. So that whole notion of just normal blanking out, people don't blank out. It's not normal.
Okay.
If you're blanking out or episodes of losing awareness, something's wrong.
Okay.
And you need to figure out what it is.
Okay. I'm curious then, demographically, what do our country's statistics look like? I don't even, are there statistics actually? But
Yeah.
what do we know in terms of demographics?
Okay.
What age groups are mostly affected? When do we see onset?
Okay.
Both of you can chime in here if you have any data on that.
Maybe I can. Let me start. So, unfortunately, we do not have clear what we call epidemiological or demographic data.
Okay.
Namibia we're still quite a while away in terms of collecting data, and I think this has got to do with our lack of a centralized sort of database that keeps, and also the fact that epilepsy is not a notifiable disease, so we don't have data. However, we do know also, sort of anecdotally from my experience, that you get largely two population groups that are at risk of developing epilepsy. Firstly is little children, okay? And this is probably related to a whole host of things, either some genetic factors, some birth-related trauma that predisposes young children to have epilepsy. And then obviously older individuals also develop epilepsy. And again, this is probably due to the fact that as you get older, you acquire lesions on your brain that accumulate. So things like strokes and tumors and infections, etc., increase. So your risk of having seizures, this is in the older population. So there's a relatively quiet period where we don't really expect patients to develop epilepsy. And sort of this is from their teens until their 60s about. Where generally somebody in this age group, you don't expect to have epilepsy. However, typically in that age group, these patients have what we call secondary epilepsy. And they usually have things happening to their brain. Most commonly, things like parasitic infections of the brain. Trauma, obviously, is a massive problem that we have in that young population group that causes epilepsy.
Okay.
Yeah.
We have a general figure for sub-Saharan Africa through the International Bureau of Epilepsy,
Okay.
which is 1% of the population. So we say that 1 in 100 people will have epilepsy, but that's wildly without our own figures
Of
added to
course.
it.
Yeah.
It's a general for sub-Saharan Africa.
Okay.
We like Dr. Vaya said, we suspect that we might have a little bit more because of parasitic infections of worms in children, of tropical diseases, and then we also have a big problem with substance abuse and alcohol abuse,
Yeah. Definitely.
the trauma.
Yeah, absolutely. Okay. No, that's helpful because, as I said, the World Health Organization says that some 50 million people globally are affected by epilepsy. And one of the rankings that I had seen when I was doing a little bit of background research said that our rate is something like 9.7, which is quite high for 9.7 in every 100,000 or something like that, which is quite high for a small population like Namibia or a small country. So I think it's important for people to understand and just be aware so that they know what to look out for when the seizures are happening or when there's any sort of onset. We have one more question here that I think speaks to the young people specifically. We have a viewer, Nambaru, who's asking, if a child has outgrown epilepsy at the age of 11, is there possibility of the seizures to return? Now, with that, I think, can somebody outgrow epilepsy, doctor?
That is, okay, let's answer it simplistically. First things first, it's quite important to realize that the risk of having epileptic seizures is never zero for anyone. This is vitally important to remember, that you are never at zero risk of having an epileptic seizure. It's part of the human condition, and it's part of having a brain inside your head that puts you at risk.
Okay.
There are various percentages in terms of lifetime risk that are thrown out there. The rough and ready percentage is about 10% of us at some point in our lives will have one seizure out of the blue for no reason.
Okay.
Because it's very common. Now, this whole concept of having outgrown epilepsy, and that's a very odd age to quote, and I suspect it's a specific question about a specific patient being asked here.
Yeah.
What makes it quite difficult to answer that question is the whole notion or the concept of having outgrown epilepsy in the first place. Right? It depends on what are you dealing with. Are you dealing with what type of epilepsy syndrome are you talking about? And I think it's always quite important for the public to remember that it's not that easy to make hard sort of predictions, especially if you're a layperson or you do not have experience in managing epilepsy, in terms of how the outcomes will be over the long term. We do know, though, that patients who've had epilepsy before are at increased risk of having epilepsy again, or at least epileptic seizures before are at increased risk of having recurrent seizures. So things that happened before tend to happen again. Right? And so I think one should just always approach these things with caution when you sort of rubber stamp patients and with absolute terms such as you have outgrown this, you are cured. It's not quite as simple as that, and it's oversimplifying a very complex body. And I think the best way to approach it is talk to a healthcare practitioner.
Absolutely.
Okay, and get really educated advice or sort of insightful advice in terms of somebody who is actually managing these patients on a day-to-day basis.
All right. Harmina, did you want to add something to that?
No, it really is individual.
Yeah.
Epilepsies are unique. Everyone's epilepsy is different, and it's personal, and it really depends on what kind of treatment, what kind of age, what kind of condition. So it's impossible to say when and if and how.
Okay. And just as we're getting towards the end of the show, there's a question pertaining to this. So I think we can just take some time to talk about the management of epilepsy or the management of one's seizures. What are the forms of treatment? Is it medication? Is it brain surgery? What exactly does somebody need to get to be able to help them manage their epilepsy?
Okay. I think if I may field it, obviously, the first prize is find the cause and treat the cause if the patient has underlying epileptic seizures, right? Obviously, and again, if a patient is having recurrent seizures and you made a diagnosis of epilepsy, the first line of treatment is medication, right? And there are various drugs that can be used to control the epileptic seizures, older drugs, newer drugs, and they all have various side effects. And again, your healthcare provider will be able to highlight all of this, the benefits of this to you. What is quite important to remember with medication is that you need to take anti-epileptic drugs routinely, okay? And you need to take them over a long period. Okay?
He needs to say it again.
All right.
Routinely and over a long period.
And I think one of the biggest risks, or sometimes what we experience in terms of patients who present with epileptic seizures who have epilepsy or uncontrolled epilepsy, is that patients do not take their medications every day routinely, which is a difficult thing, but it is something that one really has to work on, and we encourage our patients to either put reminders on their phone or find tricks to remember when to take these medications, number one. Number two, if you're experiencing problems with the medication, it doesn't make sense not to go back to your doctor, to have it looked at and adjusted if need be. This is vital, right? Number one. And number two, you'd never want to stop these medications precipitously or very quickly without the adequate advice of a healthcare practitioner, because we know that if you've been well controlled with anti-epileptic drugs and you suddenly stop your medications, you're at increased risk, significantly increased risk of having a recurrent or breakthrough seizure because you've suddenly stopped your medication. Okay? This medication has to be stopped gradually over time.
Okay.
And then obviously, we look at brain surgery for patients who are appropriate candidates. And again, typically, the brain surgery is reserved for patients who have refractory epilepsy, which basically means a patient whose epileptic seizures are not controlled by medication. And then we examine you and say, are you a candidate for the brain surgery? And if you are a candidate, then obviously we explore that, because generally brain surgery for epilepsy has very, very good outcomes in the correct patient, in the right candidate for it.
Okay.
Right.
We have a viewer here, viewer Likua, who asks, what healthcare centers in Namibia are equipped with the instrumentations like EEG needed to detect and categorize epilepsy? I'm guessing the Namibia Brain Center Institute does that, yeah? Right. And that's where you are. Just in case the viewers are not aware, that's where Dr. Vaya is. So there is the Namibia Brain Institute. And then Harmina, there is also resources and awareness and campaigns on at your organization that helps people find resources like this, if I'm not mistaken.
On the one side, yes, we work on the side away from medical.
Okay.
So we're not a medical organization at all. Also, we don't give medical advice.
Okay.
We will say, go find a neurologist.
Okay, yeah.
Or go find a test, or go find. We can't say where, but I mean, we just give the instruction of, because we work on the side where people live with epilepsy.
Yes, okay.
How to cope with it, how to stay strong, how to stay healthy, how to look after yourself and do the training and see that they get jobs, go to school, qualify, get married, be happy, that kind of thing. That's what we do.
All right. Well, we are at the end of the show. Unfortunately, we've run out of time. But Harmina, Dr. Vaya, thank you so much for indulging us in this conversation. To the audience, as always, please leave your comments below this casting. We will always direct these to the experts and try to bring the information to you. So if there are any questions that we did not get to tonight, don't be worried about it. We will pass them along to the experts. I thank you for tuning in. As always, I'm your host, Arlana Shikongo, and thank you for joining us.